Hello, good afternoon. Hello, good. Look, I know we're not in church, but if I call, you do what? Respond. There you go. So you know what you're supposed to do. Really? Somebody online's got the spirit. Okay. So good afternoon and welcome, and especially to our alums. Welcome back. Welcome back home. You know, today we're featuring the alums from one of our many important programs, the MPH-MD program. I'm sorry, but here we call it MPH-MD because the fact that you're an MD graduate is okay, but quite irrelevant to us. You are an MPH graduate, and therefore we love you, and we're happy to have you back here at your home in Tidewater. And today we have a speaker who is part of your community. One of our MPH-MD graduates, MD-MPH graduate who was also our graduation speaker last year. So we're always happy to see Deborah and to have her back here on campus with us today. So Deborah Houry, his MD-MPH, is the Chief Medical Officer and Deputy Director for Programs and Science at CDC. Most recently, she served as CDC's acting director and acting principal deputy director. And prior to that, she served for 7 years as director of the National Center for Injury Prevention and Control. Dr. Houry previously served as an associate professor at Emory University and emergency physician at Grady Memorial Hospital. She received her MD. So I didn't mean to stutter when I said MD. That was not intentional. Her MD, MPH, and MDH degrees from Tulane University, and completed her residency and training in emergency medicine at Denver Health Medical Center. She's returning to Tulane this week to celebrate the 25th reunion and I see others here have the spirit. More of our MPH MD grads. Glad to have you all back. We're proud of all she has accomplished. I don't have to read that. We're proud of all that she has accomplished, and we're particularly proud that she continues to be a dedicated alumnus and wave the Tulane flag every opportunity that she gets. Welcome back to Tidewater. Welcome back to New Orleans and Tulane. And we look forward to your presentation.
Well, thank you all. It's great to be back home and to see many of my classmates here. It's interesting because, when I was thinking about my journey and how, I ended up with public health and clinical medicine, I really think a lot of us with our work in New Orleans have the same spirit. We're very familiar, particularly like my class, having been at Charity Hospital. And there you're just on the front lines and just seeing all the opportunities to intervene early on. And I think that's that community service and seeing the patient, but also the population. So today, I just want to talk about some of the work we're doing at CDC with the hope that all of you will see a part of the work that you do in this and be able to bring it back to your communities as well. So when you talk about public health versus clinical medicine, it's certainly just easy and simple to say the difference is a patient versus the population. But it's certainly more complex than that. So public health, certainly you can say this could be more of a focus on global populations, regional populations, or having different sectors at the table. Also, I think really focusing on things like upstream factors and how do you prevent things or reducing exposures. Whereas clinical medicine, the focus largely does tend to be, although on individual patients, but interprofessional teams, looking at at-risk or established diseases. And certainly when you look at the many differences between the sectors, as you can see here, public health, healthcare systems, and clinical medicine are all interrelated. But using data to drive action, we know that prevention works to really prevent and protect health. Simple things like access to clean drinking water. This can prevent illnesses like diarrheal diseases. Certainly things like a helmet can prevent traumatic brain injuries. And hand washing can reduce the spread of things like respiratory illnesses. Something that I hope all of you take back too is that given the direct relationships that clinicians have with patients, you play a critical role in being a trusted messenger regarding public health. Clinicians also really have a role in preventing misinformation from spreading, as do all of you. I think That is something that I have really witnessed unfold over the past few years. And as public health, community health workers, all of us in the field, we have a role to be that trusted messenger and to prevent misinformation. Right now, we have a critical role to play when we're talking about vaccines, such as the COVID bivalent and being up to date on vaccines. And I mentioned last night the AOA banquet, if we're doing a good job, it often goes unnoticed, and that's okay. What it means is we were able to prevent an issue from happening in the first place or to keep it from progressing. So looking at how we really have the different levels of prevention, things like primary prevention. So when you're talking about something like drug overdose, starting somebody from misusing in the first place, looking at things like childhood trauma and how you can intervene early, taking it to the next level of secondary prevention. Maybe if somebody's coming to see you, you give a low dose opioid prescription and not a high dose. I know Joe Shue in the back has done a lot of great work on this. Or linking somebody to treatment. Tertiary would be that naloxone overdose prevention, where somebody is already experiencing disease and you're preventing the long-term sequelae. One example that I think is really powerful is talking about adverse childhood experiences. To me, this is primary prevention, as basic as you can get. So looking at things that happened to children, such as abuse in the home, whether it's physical, sexual, or emotional, but also witnessing violence in the home or experiencing a family member with mental health issues or somebody who's incarcerated. These are considered childhood traumas. More than half of the adults in the US have experienced one in their lifetime, and 1 in 6 have experienced 4 or more. When you look at how this has a cumulative effect on health, what you see is that the more ACEs you have, the more likely you are to have these chronic health conditions. And they are actually associated with 5 of the 10 leading causes of death. And so if you can prevent this childhood trauma early on, you can reduce things like kidney disease by 16%, or nearly 44% of depressive cases. So how do you do that? Because that seems really kind of high level and kind of nebulous. But so looking at things like early childhood education, nurse home family partnerships and home visitation, those are things you can do early on to ensure families have the support and kids have the support. If you're screening in a clinical practice for ACEs, you can also refer people that are experiencing ACEs to things like cognitive behavioral therapy to lessen the sequelae. And what is really important is this has intergenerational effects. There's been studies that have been shown that if you do ACEs treatment or trainings, it can reduce it in your children. And so that's why this is so important. It has lasting effects. So just to give a few examples. So starting with social determinants of health, as I think they're really instrumental to both medicine and public health. These determinants start in the environment in which we are born, live, and work, and affect a wide range of health risks and outcomes. The amount of services one has access to, like healthcare and education, as well as social environments like culture and violence, may result in long-term health inequities such as injuries, chronic disease, and decreased life expectancy. So what influences health and these social determinants? I always like to call them building blocks because I think you build everything on top of it. So things like economic stability, education access, healthcare access, the built environment, and social and community context. When you take one of these, like access to healthcare, if you don't have access to healthcare or insurance, you're less likely to get preventative screenings, less likely to get vaccinations, so more likely to have long-term health consequences. Another example I really like is when you look at environmental conditions. So if you have one of those blighted lots, one of those areas you look through and it's got vacant buildings, you're less likely to walk through that park or that area. When there's greening done there, that brings together communities, increases physical activity, and decreases crime. So the environment you are in truly impacts your health. And these are things that we can change. So what do we do as providers? One thing is the National Academy of Medicine and the American Association of Medical Colleges has now recommended screening for social needs. So we can do that in clinical settings, identifying the social needs and then working with community-based groups to really provide those services. And then what do we do on the other side from the health department or public health? Look at the data in the community. What are some of the underlying drivers, the inequities, the issues that we need to rise up and really elevate? And then how do we work across sectors with the healthcare system to ensure that we are doing those linkages? And I think public health also has a significant role when it comes to talking about evidence-based practices. And what are some of those programs that need to be evaluated or scaled up? So an example I just wanted to go over was at CDC, we now have a community health worker program. This was launched during COVID, just given the need that we saw to be much more in the field. And this program is focused on resilient communities and really links community health workers as frontline public health workers. Not only were they instrumental in ensuring that more populations were vaccinated, but they're trusted messengers and can also do things like cancer screening, talk about high blood pressure, link to community groups and resources. In Louisiana now, through some of our CDC funding, they are expanding their community health workers pilot across the state and facilitating things like peer-to-peer learning and regional networks. What I think is really important is they're also now doing social needs screenings in communities that have lower incomes and linking these community members to services. So intervening early with trusted members with community resources. So focusing on a few other CDC programs. So SetNet, or Surveillance for Emerging Threats to Moms and Babies. This was started during Zika. So I think Zika was one of those many diseases that really caught us all by surprise because we kept learning more and more about it. There are so much more things we didn't learn, like sexually transmitted, having congenital defects. I mean, all these things. It was a very complex disease. So we set up this network to monitor throughout pregnancy and then early childhood. But when we did this, we realized there were some areas of the country that certainly were experiencing more of this. So we included field staff in those areas to help collect the data, but also educate the community about risks, how to protect yourself, and what to look for. And I don't know if it's that I'm an ER doc or public health, but I think in both you learn to be versatile. And so when COVID hit, we were able to use this system to do the same thing, to monitor exposures. So we looked at COVID during pregnancy and we're able to use this to inform clinical changes. So things like if a mom had COVID 14 days prior to delivery, they were less likely to have the infant room in with them and then had breastfeeding difficulties. So they needed lactation services. So thinking about that early on to address it. We also saw that if you had in your second or third trimester and you had COVID, much more likely, about 4 times more likely to have a preterm delivery than those with a mild infection. Really, really stressing the importance of COVID vaccination in pregnancy, which was one of the under-vaccinated populations that we are seeing. Just last week, we released our new dashboard on maternal mortality. One of the things we're trying to do is much more on provisional data so that's more timely. Unfortunately, we're seeing that disparities are still occurring and maternal mortality is still a significant issue in the US. About 700 moms die a year in the US from this. So we are working with state teams called perinatal quality collaboratives in about 39 states now, working with nurses, with physicians, with healthcare systems to identify how do you have more quality care. And each group identifies different initiatives that they can focus on. One example in New England was they looked at both opioid use disorder and also breastfeeding, and they found that they were able to increase counseling by 20%, as well as naloxone use and distribution by about 25% in these groups. And then the Hear Her campaign, for me, was pretty personal. I lost one of my staff a few years ago. She was a brilliant up-and-coming African-American PhD, a scientist that worked for me. She died a few weeks after giving birth. And she fit, all of those warning signs. She'd been to the hospital, she'd been back, she was having complications. And when you look at the data, race is what's driving a lot of this. You separate socioeconomics. And so again, Shalon, She was well educated. She had, I mean, had a good social support system, but she died. And so we were trying to do more of these Hear Her campaigns to where when you have these these warning signs, to get clinicians to really listen and for women to feel empowered to say, you know, I'm having these symptoms, because we need much more awareness of what's going on. Because again, maternal mortality for our country is a staggering number of deaths that we should be preventing. So, and I promise there's happy stuff at the end, because I am optimistic about all of this. But so climate and health. So this is one of those things to where I kept thinking, this is abstract, this is environmental, you know, what do we do about it? And there's so much that we need to know about it from the healthcare field. So there's about 700 heat-related deaths a year now. And as we're seeing these climate changes, there's a lot that we can do. You know, hot weather is associated with an increase in heat-related illness, but also cardiovascular and respiratory complications, renal failure, impacts on fetal health and preterm birth. So we can do things like making sure that there are more of these extreme heat events, to have cooling centers and water sites, to also have heat health alert systems. And we've seen several states now change the number and the temperature to be able to issue these on a more regular basis. And this just shows many other areas that are now being impacted by climate and health. The two that really strike me are, you know, in Georgia now, we might see Lyme disease because we're seeing a lot of these pathogens change because of the temperatures. Similarly, there's now a lot more harmful algal blooms that we're seeing, which are resulting in respiratory illnesses. So in your environment and your city, it's important to know what are the changes that are driving some of these health conditions. I think this past year, it probably was a surprise to many of us when we had a case of polio in the US. We're also seeing measles outbreaks. And this is one of those things to where what we've tried to do is work closely in communities. When we saw the polio case, we began conducting wastewater investigation to see, are there other circulating polio viruses? And that's where we know that we need to be vaccinating even more and doing more campaigns. Similar with the measles outbreaks, we knew where the communities were, but we needed to work closely with pediatricians, again, as trusted messengers that knew the communities, and to have culturally relevant materials, because many of this was either religious driven or culturally driven. And we needed to make sure that we could have those conversations and meet people where they were so they understood the benefits of vaccination. And so speaking of vaccination, you know, health providers, again, I can't stress this enough, are such trusted messengers. And the decision to get a COVID vaccine is an important one that we should recommend to patients, including children, pregnant people, and those with weakened immune systems. Coupling vaccine confidence, safety, and effectiveness information with communication strategies can really help us seize on opportunities to increase vaccine uptake. And when recommendations are based in safety and effectiveness, patients can feel confident in their decision to get vaccinated. And this has ripple effects that can touch others in their family and the community, really bettering public health for us all. And so CDC has a free app available to provide recommended vaccination schedules. So syndemics are when you have multiple epidemics that really exacerbate it. And so things like HIV, you have hepatitis, and also drug overdose. These really have adverse outcomes in communities. So some of the things that we are doing are working with our partners to develop new multi-pathogen technology to facilitate testing, diagnosis, and linkage to prevention or treatment for multiple infections. This includes things like having a Hep A and B vaccine, or screening for Hep B and C and HIV in patients. Really important when somebody is there in your front door at your point of care to be able to address multiple things. What I think is really neat is when we're doing things like our PrEP guidelines around HIV, we have found that it lowers sexually transmitted infections because of the increased testing, diagnosis, and treatment that we're doing, and shortening the infectious time period. Also doing things like co-locating treatment and services, so HIV, STI, and viral hepatitis prevention services. This really allows us to maximize health outcomes. And syringe service programs, we've done about 30 years of research at CDC now. We have seen that they decrease HIV and Hep C infections by about 50%. When you couple that with treatment for opioid use disorder, decreases transmission by about 60%. So really important things that we can be doing. So we have a bold goal, and that's to end new HIV infections, 90% of them by 2030. To do this, we need to be looking at the communities with the highest rates and looking at the most at-risk populations. Diagnosing, so having treatment readily available. Treating, so that we make sure that we are really reaching those viral suppression levels so that people aren't transmitting. And I always think that this is one of those really great things to where treatment is prevention. This does prevent future infections. And then certainly responding when we have outbreaks, oftentimes related to injection drug use. One example of this was in Scott County, Indiana. Many of you probably remember that HIV outbreak back in, I think it was 2015. After that, we were able to institute the first legal syringe service program in that area. And what they found was after it was in place, the county had less than expected cases of new HIV, and they saw decreases in the hepatitis C cases. They also saw that of the more than 1,300 participants, they had over 11,000 visits or linkages to treatment. In addition, about 2,500 doses of naloxone were given, and 600 were reported to be used. So again, when you think about this endemic and all the ways that you're able to impact multiple aspects of health, I thought that was really powerful. So those of you that know me know that my background was really in violence prevention. And I think healthcare providers have such an important role in the community, in the hospital, in schools, in homes. One of the most simple things we can do is a trauma-informed approach in patient care. And this is if somebody comes to see you, I'm not just cutting their clothes off with their trauma shears. I'm telling them what's going to happen with them. I am not re-triggering or making their experience worse. I'm trying to approach them in an unbiased way to really explain what we are doing and then offer them resources afterwards. There's also things like hospital-based violence intervention programs like Caught in the Crossfire. And this is a peer intervention that was started out in California to where it really links clients with trauma-informed care, but also resources, maybe sometimes it's schooling or job support. They found that 98% of the clients were not rehospitalized for any violent-related injuries, and 90% who'd come from a juvenile justice system were not rearrested. Safe ER Teens is something we've been funding. It's being done in Michigan right now. And it uses motivational interviewing, skill building, such as conflict resolution with teens who come into the ER after a violent assault. It also uses cool things like cell phones to provide text messaging and also GPS tracking. So if you're going to an area to where you might have a violent conflict, just reminding you that that's one of the things that y'all had talked about. What they have found is that this has caused reductions in perpetration and victimization of peer violence, alcohol use, as well as increased self-efficacy and avoiding fighting. We can also talk about safe storage of firearms. When we talk about, childhood injuries as well as suicide prevention, storing a firearm in the house safely is very important to do. There's an intervention called Emergency Department Counseling on Access to Lethal Means, or EDCALM. And we funded the evaluation of this, and in it found that among parents who went through this is when a youth would present for a suicidal attempt. 100% reported guns were locked up post-intervention. And again, that's just talking with people about the importance of this and giving them the tools that they need. So I do think, together, we can make such a difference. We have opportunities at so many touch points in a person's life and in various aspects of the community to do so. Some of the successes that we have seen over the years are when you look at things like viral hepatitis, 750,000 Americans have been treated with Hep C medications in the past decade. Similarly, we are now seeing that for children, our MMR vaccine coverage is now exceeding the 90% target again for over a decade. So really having those impacts. And opioid prescribing, I led the first opioid prescribing guideline at CDC. We've now seen a 40% decrease in high MME prescriptions. We're also seeing a decrease in deaths from antibiotic resistance from safer stewardship, about a 28% decrease since 2013. And we're seeing the HIV deaths in the US have dropped by about 50% in teens and up. So I just want to thank all of you. I can't imagine being back at a better place, knowing that Tulane has at least 30 MD MPHers, each MPH MDs a year. And I know that this has been a really special place for many of us. And just looking at the middle row, I could just talk about all the accomplishments of my classmates and the work that they're doing. And I hope that all of you have the chance to talk with them at the reception. So thank you for having me here today. I can do questions if they want questions.
Yeah. Thanks. So we have a little time for a few questions. If you'd like to ask any questions, please come to one of the microphones. We like to use the microphones because we do have a few people who are viewing this remotely. Also, if you are remote and you have questions, please put the questions into the Q&A or the chat, and we'll read them for you. Do we have any questions from? All right. Okay. So I guess I'll ask a question. It is dangerous, I know, because I'm winging this. Any updates on MPOX?
So with MPOX, we are seeing that cases are coming down. We've at CDC actually brought it back to a center level response. But I think with MPOX, one of the things that's really important to do is, just like with hepatitis and HIV, realize that this is a time to screen for other sexually transmitted infections. And to use that as a moment to where we're screening for HIV, because we saw a lot of co-infections, but we are happy that the numbers have continued to remain low. So we are optimistic, but I think it's still an opportunity to look for other STIs and other conditions.
So, Richard.
Thank you.
Please come to the microphone. If you have a question.
Okay. All right, Deborah, thank you. Richard Oberhelman, Trop Med Department. I was fascinated by your comment about the pilot program for community health workers in Louisiana. We had another guest, another alumnus who spoke yesterday, who runs a healthcare operation in Uganda and trains community health workers. It's been very successful and improved a lot of health indicators. And I remember he mentioned he had a conversation with Tony Fauci, and he said, why don't we do this in the United States? And I think that's a great question, because so many LMICs really have this community health worker model. And it sounds like we're getting there, but is this something that CDC has a broader strategy for implementing for improving health outcomes?
Yeah, we were fortunate this past year to receive funding for public health infrastructure. And so actually Louisiana is getting about $46 million now to focus on hiring a public health workforce. And so some of that will likely be community health workers to really, I think it's great with 40% of that going to local health departments and communities. So our hope is that really does build the public health infrastructure to support more of that. I also think it's not just the community health workers, but then we look at like agriculture and some of the extender programs in rural areas. That's another untapped area, but I agree. I think community health workers trusted in the areas can really link to community populations. And it's something we just started in the past year or two at CDC and look forward to seeing more of.
I'll ask a tough question. Joe Shu, Tulane School of Medicine, class of 98. All right. Deb, you've done a tremendous amount of leadership in so many different areas. Mine's going to be a bit of a tough question is, how do you deal with the disruptors? How do you deal with even physicians that have a fair amount of influence, whether that's through academics, through big practices, through social media now, through podcasting. How do you turn the tide of a disruptor back towards science?
So really important question when I say this is where that's why I'm here. You know, like I can't do it. We need to do it. And it's one of those things to where the more we can talk about science and the more we can personalize things too. I know with vaccines, a lot of times I try not to talk about the family I have, but I talk about my daughter, you know, and I say, you know, I believe in the science. I vaccinated my child, you know, not just as a scientist, but as a mom, you know, and that I think is powerful. But I think the more that all of us are speaking about science and data and what's right for people and for communities, understanding there are individual decisions, but people need to know what the risks and the benefits and the actual data are, not conspiracies. And so I think the more that we can meet people where they're at, but we need more voices. We need many more voices out there.
Thank you. We can take, okay, we've got I think we have time for one more question. Margot, how much time do we have? 10 minutes. Okay, we can get a few more.
Good afternoon. My name is Crystal Dickerson. I'm a first year, second semester MPH health policy student. Welcome home.
Thank you.
One of the most attractive things for me as a student when I was looking into MPH programs was the alumni network. What would happen when I graduate? So I would love to ask you a question. If I would, can you put yourself back in your first year MPH MD shoes? What advice would you give yourself now that you've been so incredibly successful in representing Tulane and Large?
You know, I think it is to get to know those people that inspire you and not to be intimidated. What I have found is I gave a story yesterday at Grand Rounds at Tulane. It was an MD MPHer who was speaking. I was a first year medical student. I went up to him afterwards and said, I want to be like you someday. You do violence prevention work. You're an ER doctor, an MD MPHer. He didn't blow me off. He gave me his card. He stayed in touch with me over 8 years and I moved to Atlanta to work with him. And so I think it's finding those mentors, finding those sponsors, and then looking for opportunities to do research or community work. I think that's what really drives a lot of us. And so while you're in training, how are you then applying it? You know, because that takes you to the next level and it also helps you build networks. I think, you know, you can reach out to anybody here who's a graduate of Tulane. I don't think any of us would ever turn down, you know, a Zoom chat or something like that because we pay it forward. I think that's what we do in public health and in medicine, and certainly as Tulane alums.
Thank you.
Yeah, Dee.
Well, Dee Bowling, Senior Director of Communications here at the school. I'm curious, you know, the COVID pandemic really kind of seemed to come out of quote unquote nowhere. How is the CDC preparing for like the next thing on the horizon that we maybe haven't even thought of yet?
So I'll give you an answer and I'll give you a non-answer also. And I think because one is, you know, as I've been watching a lot of the health issues that are leading causes of death, you know, I think COVID certainly has been a huge issue and it's strained an already strained health system and public health system. So we certainly need to do things like genomic sequencing and surveillance. And we are doing that. And now we have a lot more syndromic surveillance. We're looking at emergency departments for surges and different sorts of influenza-like illnesses and working internationally as well. That being said, things like overdose, maternal mortality, suicide, firearms, we're all going up pre-pandemic. And I don't want to lose sight of those as well. That's my non-answer.
Good afternoon. My name is Brad Johnson. I'm a MD MPH TM student in my third year. Just came from my transplant surgery service, so part of my scrubs. My question is more of like a continuation of the conversation of sharing information and research and knowledge with people and meeting people where they're at. In my experience with MPOX, I identify as a queer man. There was a dearth of information from the CDC, from health departments. I think a lot of it because it didn't exist.
Right.
And in I attribute one of the reasons why we were able to contain MPOX among the MSM community was information sharing within the community and meeting people where they were at. I think that strategy, or that came out of like a need and absence of information from other places. I think my question or my suggestion is for public health authorities like the CDC to meet people where they're at, come to them on the platforms, whether it's Instagram or TikTok or Grinder.
Not TikTok, can't do that, federal government.
Okay. But the point is, like,
Yes.
the information needs to not just be on the
Yes.
CDC website. I took it upon myself to become a community advocate and to share the science and the knowledge with my Instagram stories. And I gathered a very large following across the country because I was sharing that information when no one else would. But that's just a little like suggestion that I think that the endpoints of the research doesn't meet most people where they're at, and I think we could do better there. There's something else I was going to say, but I can't remember. So I'll.
Well, while you're thinking about what I would say is I agree. And I think that's really why we need partners and community-based groups, because I could share that information on, like my LinkedIn, but people may not listen to me if I don't fit in that group. And that's where we need to be working with different groups that can help carry those messages through the communities as well. And that's why I think like trusted messengers and people of different groups are so important for this. We're trying to do more like bite-sized graphics and takeaways so that people can disseminate them in channels more. But this is truly why we need partners. And we are doing a lot more with partners as part of our CDC moving forward to look at how we can engage partners early on as we're developing guidance, our communication materials, and to make it not just an outflow of information, but also to understand what's helpful and what's going on. But thank you for that. Do you
Thank
remember
you.
part 2?
I don't remember.
Okay.
But when I think of it, I'll talk to you afterwards. Thank you.
Hi, I'm Kaylin Hall. I'm a PhD student in the biomedical sciences program. So I know that since the COVID-19 pandemic, that rates of antibiotic resistance have raised pretty dramatically in numerous pathogens of significance. So since, it's obviously a viral pandemic, what do you think was the biggest contributing factor to that? And hopefully we don't have a future pandemic of the size of COVID-19, but if there was, what healthcare policy changes do you think we should enact to prevent the rise of AMR?
Yeah, during the initial stages of the pandemic, some people had secondary infections, so we were treating with antibiotics. And I think there's also such a focus on COVID itself that some of the other practices slid. So we weren't doing the same antibiotic stewardship as we were. And we did see, as you pointed out, like a significant increase and really a backslide of it. So I think it's just reheightening what we're doing and continuing surveillance in hospitals and sharing this information to continue with appropriate antibiotic prescribing. I think we'll see a trend back in the correct direction as we're now focusing on, again, I think with COVID, a lot of it was the secondary infections and truly the focus on COVID and less on some of the bacterial infections.
So are there any questions online? Okay, we got time for one more question.
Hi, my name is Mansi Chabutwala. I'm a first year MPH nutrition student. So my question for you is a little bit more personal on your experience. Given you've worked in this line of work for a while, what is the most valuable lesson that you've learned in your experience, whether it was at Tulane, whether it was working at the CDC, when it comes to patient advocacy and community advocacy and teachings? Yeah.
I think it's really to listen to your patients and to listen to the community, but also to be true to yourself. I shared a patient story earlier about, I saw a patient with opioid use disorder in clinic. He had come to me and he had a positive urine drug screen and a prescription, and he wanted to start buprenorphine. That didn't fit with what we did in clinic. And so I told him I couldn't treat him. I wanted to treat him, but I couldn't treat him because it didn't fit with our protocol. I told him he could come back and see me and that I had an open door. I meant that. He was not happy with my initial response. But amazingly, he came back and he was one of my most successful patients. And he said, "Doc, you were tough, but I needed that." So I think for me, it's about knowing what your principles are, taking care of the patient, doing what's right for them. And so when you're in communities, not giving up, always having belief that you don't know when you're going to have an impact on somebody. You just hope that you do. And I saw that with some of my domestic violence survivors as well. I never know if any of them were going to leave their relationship or develop safety measures. I hope that they would. And some of our follow-ups, we found that they did. So I think it's believing that you're doing the right thing by caring about the patients and the populations. And I also call it my sleep at night rule. I always think if you do the right thing, you'll sleep better at night. And although that sounds simple, it's like even with a head lack in a patient, if I didn't explore enough for that last piece of glass because I was tired, I wasn't going to sleep at night. I needed to make sure I was always doing the right thing.
I think that's a wonderful message to end on. And thank you all and welcome back, alums. We have a reception out in the gallery, so please do join us in the reception hall for a little more time to fellowship. Thank you.